Anterior cervical discectomy and fusion, or ACDF, targets nerve or cord compression. Inner body fusion helps maintain cervical disc height and preserve normal sagittal alignment, the neck's side view curve. Sagittal alignment is the neck's natural front-to-back curve that keeps the head balanced. The anterior approach follows a natural space between the SCM, the large side neck muscle, and the strap muscles. It continues between the trachea-esophagus complex and the carotid sheath for midline access. Using a live X-ray fluoroscopy, the surgeon confirms the correct level before opening the annulus outer disc wall. Only once the correct level is verified does the formal discectomy begin. The disc is removed down to the posterior annulus by gently scraping and cleaning it with a small surgical tool. Bone surfaces are cleaned until healthy bleeding appears, promoting successful fusion healing. The posterior longitudinal ligament, a band of tissue behind the disc, is removed to access fragments compressing the spinal cord. This step allows full visualization and removal of central compression. Bony growths on the side of the vertebrae are removed to reopen the space where the nerve exits and relieve pressure on the nerve. The cage is a small spacer that takes the place of the removed disc. The surgeon selects a cage that restores the neck's natural curve and the normal height of the disc space. The cage sits firmly between the prepared bone surfaces of the two vertebrae. It holds bone inside while supporting weight and allowing bones to grow together. Anterior plating enhances immediate postoperative stability. Screws anchor the plates securely to the vertebral bodies. Soft tissues are closed anatomically to preserve natural planes. This careful closure reduces postoperative discomfort and difficulty swallowing. Most ACDF patients ambulate early after surgery. Many are discharged the same day or after a single night of monitoring. Fusion gradually matures over 12 to 18 months. Adjacent segment stress becomes a long-term point of clinical attention. This is especially emphasized in multi-level cervical fusions. When surgery involves 3 or more levels, there's a higher chance the bones may not fully fuse together. This is called pseudarthrosis, and it's something patients and doctors should consider together. Replacing the disc with an artificial one is an alternative treatment, but it's only suitable for certain patients. It preserves motion when degeneration is limited and stability is maintained. Motion-preserving implants are generally unsuitable for multi-level disease or instability. When decompression is precise and fusion is stable, ACDF outcomes remain reliable.